Men, stereotypically compared to women, aren't as mindful with their overall health and are not used to coming to see providers about their health-related concerns. And so sometimes, we in urology, as Helen nicely stated, are the first, physician providers who, men have seen since they were maybe in high school or even college.
Hello and welcome to our WInnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a very exciting program planned for today. We are now in our second season of WInnovations, and we're thrilled to be back in the studio in the Department of Urology here at the University of Wisconsin. With no further ado, I'd like to introduce our guests for today, Dr. Helen Bernie and Dr. Dan Williams. Now, Dr. Helen Bernie is the Director of Sexual and Reproductive Medicine at Indiana University and the Andrology Fellowship Director. She did her urology residency at the University of Rochester Medical Center, followed by a 2-year fellowship in sexual and reproductive medicine at Memorial Sloan Kettering Cancer Center in New York Presbyterian Weill Cornell Medical College in New York City. Welcome, Helen.
Thank you. I'm happy to be here.
And Dr. Dan Williams, who is the UW Medical Foundation Professor in Clinical Urology, Vice Chair for Education, and our Residency Program Director in the University of Wisconsin Department of Urology. He completed his residency at Northwestern University, followed by a fellowship in male reproductive medicine and surgery at Baylor College of Medicine. Now, both Dan and Helen, I know them personally and quite well, are very passionate about men's health, cancer survivorship, and fertility preservation, amongst other things. It's really truly amazing to have these thought leaders with us in the studio to discuss the topic for today, which is new frontiers in men's health. Once again, welcome, Helen and Dr. Williams. Welcome to the program.
Thanks, Kyle. Great to be here.
Now, I'd like to start off just by kind of paying homage to our mentors, because I think it's really, we're not here without our mentors. So maybe, Helen, why don't we start with you? Who are some of your mentors that really helped you to get to where you're at today?
No, absolutely. That's such a good point, because you're right. We wouldn't be here today without them. I think probably some of my very earliest mentors was really when I did my very first urology rotation as a third-year med student. And I actually was in a private practice clinic, and it was a doctor named Dr. Verratti. And he was the first person that really was like, you can do urology. You'd be great at urology. And he exposed me to every aspect of it, seeing patients. And then as I did my sub-Is, I met Trinity Bivalacqua and Bud Burnett at Hopkins. And those were the first two people to ever bring up sexual health with me and men's health with me. And I was like, wow. I was like, this is really a field that feels comfortable to me, that I love doing. And then as he kind of progressed, I was lucky to have an amazing chairman and Dr. Messing at University of Rochester, who also supported me and was like, academics is what you want. I'll help you. I'll sponsor you. And then, of course, in fellowship, Dr. John Mulhall and Peter Slagle and Mark Goldstein have just been instrumental. So I think so many of those people. And then even as you get to your practice, like clinical practice, Ranjith Ramasamy, who went to residency with my husband, who's also a urologist, is now, a leader in our field as well. And so he's been a great mentor in helping me build a practice at Indiana University. And so I think I'm very lucky that I really have had a lot of wonderful people who at different points in my life have encouraged me or mentored me and given me the advice and the encouragement that I needed to pursue my dreams and to go forward.
Yeah, that's great, Helen. And the great Dr. Messing, also a former faculty at University of Wisconsin. So there's a little Wisconsin connection there as well. Urology is a small world. And I continue to do some collaborative work with Ed Messing, who's now at Rochester, has been at Rochester for quite some time. What about you, Dr. Williams? Who would you like to pay homage to?
Yeah, we're all, as you've just heard from Helen, we're all products of our training and our exposures and our mentors. And I was very fortunate in residency to have two mentors in particular who inspired me to pursue men's urologic health and men's reproductive health. The two who come to mind are Dr. Bob Brannigan and Dr. Kevin McVary. Dr. Brannigan focused on men's reproductive health, and Dr. McVary is certainly a big thought leader in the urology world in men's health, ranging from BPH to sexual medicine. And so I was very fortunate enough in residency to train under both of them. And where I trained, we had a research year, and I enjoyed my time with Dr. Brannigan clinically. And then when it came up to our lab year, I reached out to him to get involved with some male reproductive research topics that he'd been working on. And that really inspired me to go into academic medicine. And during that research year, I applied for fellowships and was very fortunate to match with Larry Lipschultz at Baylor College of Medicine. And I really pay a lot of respect and a lot of thanks to my training with Dr. McVary, Dr. Brannigan, Dr. Lipschultz. Certainly without them and then their mentoring, I wouldn't be where I am today, professionally and personally. And as Helen said too, the mentoring doesn't stop. I also feel very fortunate to be in a department with very strong leadership, and very fortunate to be working under the leadership of Dr. Steve Nakata, who's our chair. He's certainly one of the great thought leaders and leaders in the urology world. So yeah, I've been very fortunate to have great role models and opportunities to train and do what I do. And under Dr. Nakata's leadership, was fortunate to start our men's reproductive health program here in our department.
If the listeners want to hear more about leadership, Dr. Nakata did a great episode on leadership in our first season, so certainly look that up if you want to hear more about leadership and mentorship. So thank you both for paying homage to your mentors. Now, I want to get into more of the topic for today, which of course is men's health. And I think we have to start basic, right? Because there certainly could be some patients tuning in today. Could be, urologists, other healthcare providers. But Helen, how do you define men's health in the field of men's health?
No, great question. So for me, men's health is really an overall encompassing everything we're doing to help improve men's health. And specifically in my practice, that involves a lot of issues related to quality of life and overall health. So dealing with erectile function, dealing with male infertility, dealing with testosterone levels or hormone levels. Because while that may be what brings a patient into my office, then it allows me to actually say, wait a minute, your hemoglobin A1C is 12. Let's get your glucose under control. Let's stop smoking. And then you're really able to impact them on an overall health level to help them fix or change or correct their comorbidities, lose weight, and kind of really tackle the things that can really not only prevent these things from occurring, but really prolong their longevity.
I think that's a great place to start, but isn't that the role of the internist, though, Helen? Or how do you think about the role definitions there?
No, absolutely. So I feel like I'm a little primary care physician inside a surgical subspecialty all the time, because we're really, as urologists, we're the gatekeepers of men's health, right? Everyone knows men don't go to the doctor. They only go if there's main things wrong, like sex or trying to make a baby. And that's what gets them in the door. So if I can get them in the door, then I can actually counsel them and I can check their lipids and I can talk to them about the things that they're doing that can contribute to their overall health. And so that's really probably one of the biggest reasons why I went into men's health, was because I felt that not only do I love improving quality of life and I'm comfortable talking about these things that we should normalize more in the US, but I can actually make a dramatic impact on their overall health. So I think absolutely as urologists, this is our role and this is our space and this is our lane, because this is who men are coming to see. Men usually aren't plugged in like women, where we go see an OBGYN, right when you start hitting either pregnancy or puberty or whatnot. Men don't really have that. So if aside from their like sports physicals during high school or middle school, they're not seeing a regular doctor. And most men don't go see a doctor until something's extremely wrong. And so being a men's health person, I can see someone that's coming for ED, and we know ED is a harbinger for cardiovascular disease. So then I can plug them in on the right channels. And for me, that's really what gives me the reward of this career and being in this specialty.
Dan, do you concur or have anything to sort of add on to that?
Yeah, I echo with a lot of what Helen was saying, that I think that one of the big points is men stereotypically compared to women aren't as mindful with their overall health and are not used to coming to see providers about their health-related concerns. And so sometimes, we in urology, as Helen nicely stated, are the first physician providers who men have seen since they were maybe in high school or even college. And those items that Helen mentioned, urinary problems, sexual function problems, fertility problems, are sometimes the first foot in the door for those men and their first entrance into urology. So to your point, Kyle, even though many of the conditions that affect men's reproductive health, whether it be cardiovascular health, diabetes, dyslipidemia, blood pressure, those types of items, even though we in urology are not specifically treating those, we have to be aware of them. And many of our patients who come in to see us are already established with a PCP, but if they're not, I believe that it's on us as the urologist to at least have that conversation maybe order some of those preliminary tests. And if we pick up on abnormalities, we can use that as leverage, if you will, to really encourage those men to establish with a primary care provider to help optimize and get under control some of those risk factors that maybe are what are contributing to getting them to see us in urology. So absolutely, I think we have to be equipped and ready to discuss those things, which oftentimes that can be hard to do, right? As urologists, we're surgeons, but we're also physicians. And even though that patient sitting in front of us may benefit from a surgical treatment that we can offer them, oftentimes there are medical things that we have to be aware of too and have good working knowledge of it. And just one other point is that even in urology, we as urologists, if we're going to see men's health, we have to be comfortable talking to men about those problems. So whether it's sexual dysfunction, reproductive health, not all urologists are comfortable, with having that conversation with their patients. And so it really needs to be, in my opinion, a urologist comfortable having that conversation with the patients, equipped to deliver the care that man needs to really help them get on the right path.
Yeah, that's great, Dan. And I think Helen sort of elucidated her passion for men's health. Dan, how did you sort of come to men's health as a career, and how did that passion sort of grow?
So for me, it started during the residency years. And I'll admit, I did not expect to go into the world of academics when I was a resident. But having trained at a place that had a research year, I kind of had to do some academic work. But I kind of got blindsided by it a bit. I started working for Dr. Brannigan and working on some projects that he was involved with. And not only did the topics and the subject matter, not only was that of interest to me, but also some of the surgical procedures, both with Dr. Brannigan and Dr. McVary, the microsurgical reconstructions that we do a lot of on the reproductive health side, the prosthetic work in the sexual medicine side, the reconstructive penile work also in the sexual medicine. I really enjoyed the reconstructive aspect of things. And as we all know, within the urology world, there's a little bit of I don't want to say the great divide, but a distinction between some of the oncologic urology and the non-oncologic urology. And I just gravitated towards a lot of the non-oncologic urology. Not that I didn't enjoy the cancer treatments, but I just found more of a passion in the non-cancer related work for men's health.
That's great. Thanks for sharing about that. I want to switch gears though and move into men's reproductive health, also known as infertility. And Helen, is there anything new and exciting in the surgical management of infertility?
No, great question. So, I think sometimes we have to back up because people don't realize that we didn't even start using microsurgery really for many of these reproductive surgeries that we do until like the 1970s, which really isn't that long ago. And then it wasn't until 1978 when IVF or in vitro fertilization was first developed, which was a complete game changer, allowing couples that previously would have only options of either donor sperm or adoption. They didn't have any other option. And then certainly we developed ICSI or intracytoplasmic sperm injection, which allows you to use just one sperm. And this was great for those men with severe oligospermia or azospermia to be able to actually father children. And then, Dr. Peter Slagle, who developed the microtesty, which was just a huge game changer for these men in 1999. So, since then, I think these have really been some of the biggest changes that have been game changers for patient outcomes because previously these patients didn't have any other options. Now if you're looking kind of towards the future, the idea of using AI or artificial intelligence and having these programmed algorithms that maybe one day will be able to be used to help look at a testicle and be able to quickly scan and say, this tubule is going to be most likely to find sperm when you're doing a procedure called a microtesty, which is what we perform for patients that have what's called non-obstructive azospermia or no sperm in the ejaculate, and there's not an obstructive cause that we can identify. So I think these things are really exciting. I don't know that they're in full force and all the little tweaks have been worked out yet for many of these things, but for me, certainly that's one of the areas that's really exciting. If there's something that we could do that would better predict where we can find sperm and how quickly we can use sperm. And so I think that that's certainly avenues for future.
Yeah, thanks, Helen. I think you really hit a lot of the high points for the surgical management of infertility. But Dan, can you bring us up to speed on any of the medical treatments for male factor infertility?
So it kind of depends on what that patient is presenting with. If you think of the male reproductive system, there are a lot of parallels between the male reproductive system and the female reproductive system. The pituitary gland being kind of the hormone control center in the brain, and specifically in male fertility, the pituitary sending signals to the testes to produce the two functions of the testes, right? Producing testosterone and sperm. So there are some times where men come in and there's a clear problem with that pituitary gland, the hypothalamic pituitary gonadal axis. So as much as I wish I could say, yes, there is one magic pill that we can give all of our men that can help with their fertility, there's not always that case. But there are many times where we find during the evaluation of their infertility, specifically if they have a very low sperm count, we find hormone abnormalities that can be treated with different medications. Whether it's a man whose pituitary is not working normally because of something severe and something obvious like a history of a brain tumor and had either radiation or surgery to the pituitary area, where we're supplementing those pituitary hormones with different medications. Or, one thing that I think is also a theme when we're talking about men's health and men's reproductive health is just men's overall health. So we do see a lot of men who are overweight, and obesity is quite prevalent in the U.S. And not to say that obesity causes male infertility, because it does not directly cause male infertility. But sometimes some men who are overweight, there can be hormone abnormalities that can be treated medically with certain medications to optimize things for them.
Excellent. Yeah, thanks, Dan. Moving on a little bit now to our next segment, I wanted to get into your thoughts on some of the men's sexual health areas. And I've seen a lot of advertisements, billboards about these sort of male enhancement clinics. Helen, what are your thoughts on some of these ads that you might see?
My gosh, they are all over Indiana. I see them everywhere. But no, I'm not a fan of these clinics at all. And I'm interested to hear Dan's thoughts too. But, these men's health clinics, the problem with them is that they just pop up. They take patients. They don't ask a lot of questions. They don't get into a detailed medical history. Many of them don't perform physical examinations, and they don't follow patients correctly. So, for example, one of the biggest men's clinic advertisements is either, testosterone, come and get your T fixed. And they bring these young men in who come in. They don't ask any questions about, are you interested in fertility? They prescribe them testosterone. They don't check follow-up labs. I have the patients end up coming to see me in the office after they're tired of paying, thousands of dollars every couple months for these treatments. And they're like, yeah, we're interested in starting a family. Or maybe they're coming to see me because they're infertile and they have no idea that it's because they were started on a testosterone therapy at one of these men's health clinics. It is not uncommon that I see guys come to see me from these clinics as well that have hematocrits through the roof, predisposing them to clots or DVTs. And it's just so frustrating. A lot of recent data has really come out looking at these men's clinics that's been at conferences and published. And they did these like secret shoppers, where you like call the clinic and you act like you're interested in something and one of their treatment options. And these people are not asking any questions. They're not asking about fertility. Even when patients were saying, I'm interested in future fertility, they still prescribe them testosterone. So, I'm not a fan of it from that standpoint. I'm also not a fan of them. Many of them offer shockwave therapy or platelet-rich plasma and many of these restorative therapies that we have for ED. And some of them will even use radial waves or shockwave machines that have no data that literally are like you just going across the street and shining a flashlight on your scrotum. Like it's not going to make any difference. So, it's really frustrating because many of them are, as you know, cash-based. And so patients, they kind of pry on men's devastation or their hope, and they bring them in, they charge them lots of money, they don't follow up with them, and they don't see these results. And so, I'm not a fan at all. I could talk about this the whole podcast, but I'll be quiet because I'd love to hear Dan's thoughts too.
Yeah, so what I heard there was scrotal tanning is not in, is what you're saying.
No, bad.
Dan, what do you think about these sort of clinics, these pop-up clinics, these billboards, these ads that go direct to consumer advertising?
So I kind of have the love-hate relationship with these clinics. So to Helen's point, the problematic side is that men have these men's health issues. They see, the ad on TV, or they heard something on the radio, or they saw the billboard, and they're nervous, they're anxious, they're embarrassed. So they kind of see this as like, this is my opportunity to go and get fixed. get my problem treated. So on the one hand, it's very problematic, as Helen nicely stated, that men go to these clinics. They may or may not undergo a full evaluation to really try to figure out what's going on with that man. They may or may not receive a medically indicated treatment. They more likely than not are paying cash for these services, and under the supervision of whom? Who is providing that care? Is it a urologist? Very rarely, if ever. Is it an endocrinologist who specializes in men's health? Not usually, very rarely. So these clinics are often staffed by medical providers who are not specifically trained in these conditions that they're addressing. So it's where this kind of acute intersection between business and healthcare is met. But on the flip side, they are meeting an unmet need by the general medical community. These clinics are alive and thriving, and they are seeing many, many men. So one of the big questions there is, why are these men going to these clinics? Why aren't these men going to their primary care provider? Why aren't these men going to the urologist? And certainly there can be a lot of answers to that, but many times they already have, and they didn't like the answers that they got, or they already have seen a PCP or maybe even a urologist who didn't spend the time with them that they wanted or needed, or didn't have the right resources to provide them the care they needed. So for that reason, a lot of men become very guarded about the kind of more traditional system, saying, well, I tried going to the urologist. They didn't help me. So I'm going to this clinic. It sounds like this clinic will be happy to help me. So I appreciate that they are meeting an unmet need in the medical world, but I do have concerns in many cases about how they're delivering that care.
Yeah, those are some great points. Maybe even some opportunities for research into some of these clinics as to how they operate, and really good discussion. I wanted to stay on the topic though, but shift a little bit to surgery for erectile dysfunction. Now, it's usually last resort for patients with ED, but what have been some of the novel developments in recent years, and is there anything new in the pipeline, Helen, that you're aware of?
No, yeah, absolutely. So I tend to think if you have failed pills, if PDE5 inhibitors don't work anymore, a penile implant is always an option. So it's not technically a last resort, but certainly an option that you would give to someone before trying, more non-invasive things like oral medications. But we do have the new Tenaccio pump. It's the first change or new development in a penile implant in over 20 years. I think this is really exciting, and the goal of this new pump design is just to make it more user-friendly for patients, because the pump, or for people that may be listening and don't know, a penile implant is where you have two cylinders that go into the penile shaft. You have a pump that sits in the scrotum, and you have a reservoir that holds saline that usually sits in the space of retzius or in an ectopic location in the abdomen. But the part where the patient interacts with the device is the scrotum. And for all of us that place implants, that can be the site where it's frustrating when you're teaching patients how to do this, or maybe some of your patients that maybe have a little more frailty, have difficulty manipulating the device, or of course, hematomas, right? These are where a lot of complications can occur. So I'm excited to see how this new pump is going to be. I'm excited to see if we're going to notice differences in ease or maneuverability for patients. But aside from that surgery option, I think as we kind of alluded to earlier, a lot of things are focusing on restorative therapies, right? Is there any way I can reverse your erectile dysfunction and bring you back to your 18-year-old self? And the data there is a little mixed. I think luckily right now we're starting to have some randomized controlled trials coming out that are actually looking at shockwave therapy, looking at platelet-rich plasma, and trying to figure out, are these modalities going to be useful new adjuncts that are actually going to make a difference? Currently, these restorative therapies are not recommended by the Sexual Medicine Society of North America, which is our governing board for sexual medicine experts, and it's not recommended by the AUA. However, some of the new randomized controlled trials that have come out have shown some improvement in erectile function with some durability of at least up to 6 to 9 months and using shockwave therapy in patients. But right now, I think it still should be something practiced under a clinical trial or whatnot. But another option is what's called platelet-rich plasma. And this is where you take someone's own blood and you spin it down, And the goal behind this, or the thought behind this, is that you're going to inject it back into the penis, and these growth factors that are in your platelets are going to stimulate, regeneration and neovascularization and collagen production and all of this great stuff in the penis to help you with your erections again. And, again, we got our first American randomized controlled clinical trial that came out it came out and we talked about it at the SMSMA in October. But it actually showed it was no different than placebo. So, I just think that we should be cautious with these things. I do think there'll be a role for them. And I think we don't know yet maybe what exact is the perfect patient. Is it the patient that's still a pill responder and wants to get off pills? Is it the patient that just stopped responding to pills that we can get them back where they're responsive to pills? And as urologists, we're going to be having patients come in because, just as Dan alluded to, they're going somewhere else for it. They're going to men's health clinics. They're figuring it out. So I think as urologists, we just should be astute on the data that's out there. We should understand what's the proposed mechanism of how these therapies work, but really be able to discuss them with our patients, explain the data, and kind of go from there. So, I'm excited. I'm hopeful. I think that there probably is a role where shockwave therapy is going to be for maybe patients with mild to moderate ED. I just don't know who are those perfect patients. What's the perfect protocol? How many shocks do they need? I don't know those things. So I'm kind of waiting to have a little bit more data come out for all those good things.
And is Dr. Nakata going to let you use his lithotripter, Dr. Williams?
That's a pretty big machine to focus a lot of energy on a pretty sensitive area. So probably not. I hope not.
And Dan, what are you excited about that in the surgical management of ED area currently?
Yeah, so just to go back to some of Helen's comments just real briefly, there are these ideas out there that certain non-surgical therapies can help restore or regenerate the erectile function in a lot of men. And I think one of the challenges that we're all facing is that every man's erectile dysfunction comes from different etiologies. And there's, maybe I alluded to this earlier about there's not a magic pill that's a one-size-fits-all for fertility. So there's not a magic treatment per se for erectile dysfunction. So my hope is that some of these novel therapies, as we look at them more rigorously in these randomized studies, can help us figure out who ultimately is going to benefit from these treatments. Maybe there is a classic patient who will benefit from shockwave therapy. Maybe there is a classic patient who's going to benefit from some of these injectable therapies, whether it's the platelet-rich plasma, stem cell technologies, neovascularization. And then similarly, hopefully we find out that which patients won't benefit from these therapies, so that patients don't undergo unnecessary treatments, the time it takes to do those, the cost it takes to do those, knowing that they're not going to be very effective for them. So that is one of the frontiers in sexual medicine that I think a lot of us are waiting to find out. Are these effective? If so, who are they effective in, and how can we deliver those treatments best to them? And then just one other comment about these kind of non-surgical management treatments. For better or for worse, the world of nutraceuticals is alive and well. And again, people see ads on TV or hear things on the radio. Take this medication or this supplement, and it's going to restore you back to whatever famous athlete is on TV, marketing and advertising. Also have to be very careful with these supplements. In the supplement world, supplement companies are not mandated to put on labels what is in those products. So we on the consumer side, both as patients and providers, we don't really know what are in these supplements. And that's potentially risky for some patients who, depending on what medications they're taking, might have bad interactions with whatever's in these supplements. So we have to be very careful about recommending or prescribing supplements to our men's health patients. But to circle back to your question, Dr. Richards, about kind of new frontiers of surgery and such, the new pump from one of the companies that makes penile implants, that's an exciting advance in the shape of the pump, the tactile feel of the pump to help out patients. And wouldn't it be nice if in the future, everything's going to our smartphones, maybe one day there will be a smartphone activated penile implant, right? So you don't even have to find where the pump is. Just for the comfort of your own phone, just click the button and it's activated, click the button, it's deactivated. That would be something neat to pursue in the future. But yeah, so it's always neat to see these advances over time and working with industry as urologists to help optimize products for our patients.
great points, and I think it is an exciting time to see where these trials wind up and see what industry and the collaborators come up with. I think it's really neat stuff. I want to shift gears a little bit to our last segment. So we've talked about men's reproductive health, men's sexual health, and now I want to talk a little bit about men's pelvic health. Maybe I'll start with Dr. Williams here. So Dan, what's your approach to some of the various aches and pains in the pelvic area that impact men of all ages? It seems like, it's highly prevalent and oftentimes frustrating for primary care, and many times they'll send them on to the urologist for these sort of aches and pains, whether it be scrotal pain, penile pain, pelvic pain. So what's your sort of approach to these folks? I know that's a tough question because it can be fairly broad, but what are your thoughts?
It's a tough question, but it's a great question because it is quite prevalent. Depending on the different databases you look at, up to 10% of all men, so that's a lot of men, struggle with some pain issue in their pelvis, whether it's penile pain, testicle pain, groin pain, perineal pain, and it's challenging because it is a major has a major impact on quality of life of those men. They're in pain, can be distracting from work, can be distracting from their sexual health. All right, sexual function is supposed to feel good. It's supposed to be pleasant, but many men suffer from pain with sexual activity or from their daily activities at work. So one of my approaches to this is, number one, listening to that man. What exactly is he struggling with? Does he know if there are any triggers to his pain? Does anything make the pain better or worse? Sometimes that answer is yes, and that can help you really hone in on what's going on. Other times it's kind of random, and there's not an identifiable trigger to that man's pain. And a very careful, meticulous physical examination of that man can oftentimes tell you what that man needs. If he reports pain in the testicle area and you examine him and he says, yes, that's the spot that hurts, or sometimes it's difficult for that man to identify exactly where it hurts. But the pelvic area is a very complex area where there's a lot of interaction with nerves and muscles. The pelvic floor can interact with the nerves and muscles. So then the management of it kind of depends on what you find. There are times where empiric medical therapy can get men feeling better. There are times where we can pinpoint where the pain is coming from and have targeted therapy to the nerves of the pelvis, the nerves of the testicle, either with microsurgical techniques, radiographic ablation of these nerves that are causing pain. And we do, at least we here at UW are very lucky to have a wonderful pelvic physical therapy team. And many times the aches and pains down in the groin and the pelvic area in men and in women is due to muscle dysfunction in that area. And we're very fortunate to have a terrific team here at our institution that can investigate the pelvic floor musculature. So it really needs to be a personalized approach to that man's specific aches and pains in that area.
So definitely not a one-size-fits-all approach is what you're saying there, Dan, and I think you said it well. Anything to add to that, Helen?
No, I just echo everything Dan said, because most of the time these patients, when they come see us, they've already seen several other urologists or several other doctors. And so it's so important to listen to them and to let them know that, hey, I'm validating you. I believe that you have this pain and there are things that we can do to help. And I just think that, pelvic floor physical therapy is such an underutilized technique and therapy that can be extremely beneficial for many of these men and women alike. And it's not something that we're taught about. We're not taught about pelvic floor physical therapy in med school or residency. I didn't even hear about it outside of residency, except for Kegel exercises, right? For your post-prostatectomy incontinence. But pelvic floor physical therapy has really dramatic improvements and dramatic roles, as well as looking at patients and evaluating for spine pathologies, with some very quick, easy to replicate exercises you can do in the office that don't add a minute and a half to your examination. You can really help diagnose and really pinpoint the exact etiology of your patient's pelvic pain. But I just think that this is such an underserved patient population, and so many doctors and urologists, they don't want to see these patients because they don't feel that they can offer anything to these patients. And it's frustrating because we as doctors, we want to fix people and we want to help people. But there are actually many things we can offer these patients. And it starts by, number one, listening to them, doing a great physical and medical history examination, and then referring them. Again, pelvic floor physical therapy is really one of my mainstays. And then, as Dan alluded, there's many other options leading all the way up to spermatic cord denervations and other treatments.
Great points, both Helen and Dan. So screening for cancers, I wanted to touch on that, such as prostate and testicular cancer. Helen, can you sort of talk on what sort of current state-of-the-art recommendations are for screening of these cancers, and maybe in your opinion, which providers are responsible for initiating these conversations?
I will probably let Dan go over the newest guidelines on prostate cancer screenings, but I think, right, anyone that has a family history, anyone that's 45 and up, with a high-risk history or, 54 and up, you should screen for this. And I think it's anyone's role. I think it's a urologist's role. I think it's a primary care role. I think it's our job to ask patients, have you had all your screening tests? Are you up to date on your colonoscopy? Are you up to date on your PSA? Because again, sometimes we're the only physicians and the doctors that they're coming to see. Very lucky being at Indiana University, where we're a testicular cancer mecca with Dr. Einhorn and Dr. Carey and Dr. Masterson. We see so many of these patients, and unfortunately the U.S. task force, no longer recommends routine testicular examinations, which is crazy to me. But I still teach it when I'm teaching the medical students, and I'm still telling all my patients that are, under 45 that you should be doing a monthly exam. And they'll say, well, what am I testing for, Dr. Bernie? What am I looking at? And I'm like, you just want to know what feels normal to you. And if you know what feels normal to you and you're comfortable with your body, then you can help detect things earlier. And when we find things early, they can be treated better. I think trying to say that it's only one, the primary care doctor's job to do it, or just the urologist, I think kind of does a disservice. It reminds me of female sexual health, where, none of the OBGYNs were asking about sexual health and none of the urologists were asking about it. So everyone was just pushing it off on someone. But it's all our jobs, right? It's all our jobs to talk about it. And even as a men's specialist who I treat men, for male reproduction and sexual dysfunction, I still treat a lot of their partners, meaning I'm still counseling about female sexual health issues, because if I fix his erections, but sex hurts for her, then what have I really done to help this patient? So it doesn't mean that I have to treat them specifically, but at least having the background understanding and knowledge to say, you know what, you may have an issue and need some topical estrogen cream. Here's who I can refer you to who can take good care of you. And so again, we get this holistic approach to taking care of the patient and the couple.
And Dan, any similar sentiments, or do you have anything in addition that you think about when it comes to screening patients for testicular or prostate cancer?
Yeah, so testicular cancer can certainly, even though we think of it at its peak incidence in the men in their 20s and 30s, it can span the whole lifetime. So, most men who shower on a regular basis, they should be cleaning that part of their body. So, taking an opportunity to say, hey. Saying, when you're in the shower, whether it's once a month to check yourself, but just to have some sort of awareness of what their normal is. And if one day they notice that there's a new lump down there, whether they're 23 or 53, to make sure to let their provider know and follow that up with an ultrasound of their testicle area. Prostate cancer, sure, over the last couple of decades, things have changed over time about our friend the PSA blood test and the proper role. And I remember having very similar discussions when I was a resident during my training. And I think all of us, whether you're in the oncology or the non-oncology urologic world, I think we're all waiting for something that's going to be a bigger and better test for prostate cancer than the PSA blood test. I think there's a lot, in my opinion, and hopefully supported by the data, there's a lot of value in the PSA blood test. Is it the end all be all? Is it perfect? Absolutely not. I don't think any urologist would say that's a perfect screening test. But the data shows that proper PSA screening can lead to early detection of prostate cancer and can lead to better treatment and saving lives. As Helen alluded to, maybe 10 years ago or so, there was what, in my opinion, was the unfortunate USPSTF changing, upgrading, downgrading of their recommendations about PSA screening. But fortunately now it's more widespread and the awareness of it is there. But sure, wouldn't it be great to be able to pee into a cup and say you do or don't have prostate cancer? Or more importantly, pee into a cup or do a blood test and say, not only do you have prostate cancer, but it's the kind of prostate cancer that we need to treat, as opposed to one that may be a very indolent, slow-growing one that may never need to be treated. But certainly going back to I feel like there's no one size fits all. That's, I guess, my theme today. But sure, I mean, if you have a man, whether he's in his 40s or his 70s, and if he has good life expectancy, good longevity, sure, that man should be checked for his prostate cancer. But whether that man is young or old, if he's unhealthy and isn't going to be living very long due to other medical comorbidities, you probably don't have to pay as much attention to his prostate. But it's important for us, when we have a man in front of us in the office to at least inform him and counsel him about, don't forget about your prostate when you're older. Helen and I do a lot of vasectomies when men are finished with family planning. And going back to what we were saying before, sometimes that is an opportunity. If you have that 30, 40-year-old man in the office for a vasectomy discussion, we might be the first person he's seen in 20 or 30 years in the medical world. And so I personally use that vasectomy discussion as an opportunity to say, hey, by the way, do you have any prostate cancer in your family? Oh, you do? Well, then maybe you should think about getting that PSA checked at some point in your 40s. Oh, you don't? And you're not African American? Okay, maybe we can wait until your 50s to get that blood test done. So again, just patient education, increased awareness of all these things for screening.
That's great. I really just want to say thank you, Dr. Bernie and Dr. Williams. This has been a great show, New Frontiers in Men's Health. We've talked about a lot of things, three main sort of areas: men's reproductive health, men's sexual health, and then finished with men's pelvic health. And I really want to say thank you for being on the program today, Dr. Bernie and Dr. Williams.
Thank you so much for having me. This was fun.
Thanks so much for this opportunity. Really enjoyed it.
I want to thank the Department of Urology, our boss, Dr. Steve Nakata, as well as our producer and editor, Sandra Miller. And we've really enjoyed this program here on WInnovations, and thanks so much. Have a great rest of your day.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.